2 minutes. Good morning, one and all. I'm extremely thankful for the organizers of this hybrid CME program, Dr. Selvam, Dr. Kannan, and President of Tamil Nadu IPS, Dr. Sabrin Ross, and the guest of honor, Dr. IPS South Zone President-elect, Dr. Arul Prakash. And I am very privileged to introduce the speaker, Dr. Kailash Suresh Kumar. He is currently is a professor and head of the Department of Psychiatry, Chettinad Hospital and Research Institute, and he is a guide for many MD and PhD theses. He has completed his MBBS from PSG Medical College, Coimbatore, Tamil Nadu. He has completed his PG in MD Psychiatry from King George Medical University, Lucknow, and he has completed his DNB from the National Board of Examination. He was previously working in the Center for Addiction Medicine, Adult and Geriatric Psychiatry in Enhance, Bangalore. He is the recipient of Dr. M.B. Ashok Memorial Award for Best Research Protocol in 2024 from IPS South Zone. He was also the recipient of Dr. M.A.M.R. Mutaya Award for Excellence in Research Publications in 2023. He is also the recipient of the National Young Scholar Award in Psychiatry in 2011. He has been a resource person in ANSIP, ADICOM, NIMHANS, IPSTN, and South PGCME. He has authored 40 indexed international and national publications, 4 book chapters, and he is also the convener of Indian Psychiatric Society Spirituality and Mental Health Task Force. His area of interest are adult, geriatric, and addiction psychiatry, and also in psychopharmacology. And to say a few words about today's topic of the use of psychedelics in the treatment of psychiatric disorders, is a very evolving, recent, and also slightly controversial, very important breakthrough research in psychiatry in current days. Psychedelics were extensively researched in the 1960s and 1950s in the treatment of psychiatric disorders, but somehow or other, the United Nations has declared in 1970s these psychedelics, for example, LSD or MDMA or Psilocybin, are having extensive toxic effects, side effects, and they should not be used in clinical research in 1970s. So the research which has been conducted in 1950s and 1960s were abruptly stopped after 1970s. But fortunately, in the last 2 decades, research have been allowed again, and phase 1 and phase 2 trials have been done extensively in the last 1 or 2 decades, and we have new horizon, new knowledge in the field of psychedelics in the treatment of psychiatric disorders, especially for depression, anxiety, addiction disorders, and OCD. Phase 2 trials, many phase 2 trials are available. Systematic reviews are available on those phase 2 trials. And we have certain findings. And even though those research findings are not sufficient to recommend for a regular clinical use, those research findings are sufficient to warrant for further systematic research in the field of psychedelics and psychiatric treatments. So this is the current scenario, and I hope and I expect Dr. Kailash Suresh Kumar to throw his lights on this very necessary topics for the practicing psychiatrist. What is the current relevance of this topic in the day-to-day practice or in the future of psychiatry? And I welcome Dr. Kailash Suresh Kumar to deliver his address. Dr. Kailash.
இல்ல இது mention it in the comments. Yeah. Okay. So let's start with the topic. So a very good morning to all the dignitaries here, teachers and teachers of teachers here. So very happy to have got this opportunity from Dr. Selvan sir and Dr. P.P. Kannan sir, who had given this wonderful opportunity to be the first speaker in the Tamil Nadu IPS office hybrid CME. And also I thank Dr. Arul Prakash sir and Dr. Malayappan sir for such an wonderful, generous introduction and setting the stage perfectly for the topic. I think he clearly, concisely described the whole topic and the discussion. So moving to the topic. So the topic we had thought of is psychedelics in the treatment of psychiatric disorder, something that is generating some interest and curiosity in the minds of the listeners. So this is the word cloud. When we had mentioned what is up with psychedelics. So these are the words that comes up in this thing. So in the word cloud. So we'll proceed on to first knowing what is psychedelics. Yeah. So many postgraduates are also there. Many senior psychiatrists are also there. Yeah. So the word psychedelic is a Greek word having two divisions like psyche or the mind or the soul and delos meaning to show. It was first coined by Humphrey Osmond. The word literally he wanted to mean that these drugs have a mind manifesting capacity or it reveals the beneficial properties of the mind. So there were a lot of reservations at that time also that it could also be problematic to outwardly say that these medications have useful or beneficial properties of the mind. Now, this is a topic where, as we go in for usage and as we further explore about the topic, the role of regulations, the role of politics, the role of NGOs, and the financial aspects of behind these medications all come into play in how we plan for our day-to-day treatment. So these things would determine the current status of these medications today. So psychedelics are medications which cause an altered state of consciousness with some changes in the perceptual, somatic, cognitive, and affective process. No, we would hear of the trips which is caused by the LSD. So that is sort of the changes which is produced by these psychedelics. Previously, they had thought of terms like psychotomimetic or hallucinogens. Psychotomimetic meaning it produces a state like psychosis, but later they felt like it doesn't mimic psychosis. It's something different. And also they called it as hallucinogen. But it doesn't just stop with producing an hallucination. It adds something more. And the name debate for the name still remains. Yeah. So there's another group called as enactogens. These medications also we would see these medications are those which as make a person introspect about themselves and increase their self-awareness. That is what they claim. And empathogens are those medications which increase the sociable nature or the pro-socialness or openness. So these are the few terms which are used, and these are sometimes interchangeably used also. So moving on to one classification, which is based on the pharmacological profiles and chemical structures. The classic psychedelics are the medications which work through the 5-HT2A receptor and they act as agonists in them. LSD, Psilocybin, and Ayahuasca. And the next group are the empathogens and enactogens. The main medication, the main compound which comes under this study is MDMA. So these are the main compounds which we will be discussing today. The other psychedelics are also NMDA receptor agonist, ketamine, and dextromethorphan. So these medications, we would see, like when I was doing my post-graduation, ketamine was not actually used in our clinical practice. Now it is available as an initial line of treatment for suicidal ideas. Now we have a combination of dextromethorphan and buprenorphine. So these things are coming in our market, and day to day this is being used in our clinical practice. So down the line, what would be the future of these molecules is what we might have an idea from this discussion. There are also atypical hallucinogens, which is ibogaine. So what we know about these molecules till now, in ICD-11, these molecules are mainly described for their potency for abuse as hallucinogens. You would see in as disorders due to use of hallucinogens, and MDMA and MDA, and also to the use of dissociative drugs like ketamine and phencyclidine. So to make us clear that these drugs are clearly prohibited drugs, LSD, psilocybin, and dimethyltryptamine are all prohibited drugs in India, and it is not allowed to for production, distribution, or possession of these drugs, and we can't prescribe these things in India. Now, moving on to the next status. What is happening worldwide? These medications are the current legal status of psychedelics around the world. Australia has become the first country in the world to legalize the use of psychedelics for patients suffering from post-traumatic stress disorder, MDMA, and psilocybin for treatment-resistant depression and MDD. So they have legalized this for the therapeutic use, where psychiatrists can prescribe them to these patients in 2023. In US, though the psychedelic therapy remains illegal at the federal level, it has been criminalized in certain cities like Denver, Colorado, Oakland, and California. Psychedelics are still very much controlled in UK. In parts of Africa, ibogaine, which is also used locally, is used as treatment in opioid use disorder. So now, from what we know, this is the new horizon that is opening, that these medications have been started to be used as treatment for psychiatric disorders. So this word is used many times when we try to understand the history behind psychedelics. The word is back to features. Here we have gone back to try to bring out something which can help to our patients. These plant hallucinogens have been used since ages, from the time of Vedas in our ancient religious and medicinal practices and customs of the time. But bringing them into modern medicine, a significant role was played by this chemist. This chemist's name is Dr. Alfred Hoffman. He is the father of LSD. After around 25 attempts of trying to stabilize the molecule, LSD-25, and when he was working in the Sandoz Pharmaceutical, was produced by him in 1938. So he kept it aside after producing for a period of around 4 to 5 years. And it was on this day, in April 19, 1943, when he accidentally came in contact with the substance. Like he was handling the substance and somehow he touched his eyes. And gradually he started feeling the effect of these medications, these perceptual abnormalities, all these things he experienced, and felt that there is something else in this molecule which he is not fully understood. And this day, he rode a bicycle after that, and he has documented this experience after that. Till now, it has been recognized as the bicycle day in the counterculture. So this is the background of how LSD came into existence. Later, a psychologist also introduced the mushrooms to him. So he extracted psilocybin from these mushrooms. The hiatus of the research, first the surge came. Like in 1950s and 60s, after Hoffman had introduced this LSD and psilocybin, he distributed it to many psychiatrists to start using it. They used it in 2 doses, the psycholytic dose and the psychedelic dose. Psycholytic dose is the low dose which he was using, and psychedelics is a relatively high dose, and these were used as in assisted therapy. Around 1,000 scientific papers enrolling around 40,000 subjects were done between 1950 and 1960s already. And these molecules were becoming a lot popular. When these things become a lot popular with very less regulations, now what happens is that they start being misused. And it started being used by the public, hippies, and people also started to abuse it. Now, one political problem also happened at that time. The Vietnam War and all those things were happening, where President Nixon was not comfortable with the antagonistic views raised by many people, and from this group also. He felt that these drugs had a lot of influence on the people having a counter opinion. So this is called the counterculture, and he declared a war of drugs. So in 1970, by Controlled Substances Act, these medications were brought into Schedule 1. And this prohibited all the research on these molecules. There came the hiatus. For the last 50 years, we haven't had much ongoing research on these molecules. Though research was possible, it was very much regulated. People were not comfortable doing the whole process, grants, and all those things. But some NGOs persisted in propagating the usefulness of these molecules. One particular NGO was the MAP. So they advocated continued research, and thereby few trials kept on happening. Then breakthrough therapy designation was given by US FDA in 2019 and 18 and 19. This is one step. No, these FDA has not approved this medication. They found that the initial effects were good, and they approved psilocybin for treatment-resistant depression, and again psilocybin for major depressive disorder in 2019, and MDMA for therapy assisted with in post-traumatic stress disorder. This became an watershed moment. It opened up the gates for many researchers to take the topic and again do a lot of research. And Johns Hopkins University and Imperial College London established specific centers for psychedelic research. There were 2 seminar series on NIH psilocybin research speaker series on 2018 and 19. Clinical trials started testing them in other indications apart from depression and anxiety, for anxiety and depression in terminal illness, eating disorders, PTSD, substance use disorders, and other chronic pain also. And we saw such a resurgence in research publications. Almost 1,300 times increase in the yearly publications in psychedelics compared to what was there in the last 20 years. From 50, it almost rose to 700. This was the data presented by Nora Walco, the director of NIDA, in 2022. And this was the increase in the interest. Articles came in Nature Medicine, where MDMA-assisted therapy for severe PTSD, a randomized double-blind placebo-controlled study in the 3rd phase. And this is the article, Back to the Future, the Therapeutic Potential of Psychedelics in NEJM. And another article, Psychedelics Therapy, Threshold of Therapeutic Evolution, Neuropsychopharmacology. And now in 2024, we have a meta-analysis. Enough studies have come up for us to plan or put together a meta-analysis, efficacy and safety of psychedelics for the treatment of mental disorders, a systematic review and meta-analysis. So now that we have set the stage that these molecules have been spoken about a lot, let's know something about what these molecules actually do in our body. So this is about the psilocybin and LSD and DMT, which is the actual molecule in ayahuasca, and MDMA. As ketamine and dextromethorphan is already there in our market, I'm focusing less on that and thinking about these molecules. Psilocybin, mainly, the main action of these psychedelics is that they act by agonism as the 5-HT2A receptor. And other 5-HT receptors are also there, like 5-HT1 and 2C. What they basically do is, after attaching to the receptors, it increases the signaling proteins in the postsynaptic neurons and increases the growth factor and the BDNF in the postsynaptic neurons. And they modulate the synaptic plasticity. This dendritic spines of the neurons has always been considered as the marker of synaptic plasticity. It's known that these molecules can increase the synaptic plasticity and help. So now psilocybin main action is to the 5-HT2A receptors. LSD, apart from 5-HT2A, also acts on the dopamine receptor. MDMA, apart from the mentioned actions, it also has an action on the monoamine neurotransmitters, and one very important action is increases the oxytocin, thereby increasing the prosocial behavior. So now we'll go on further about these molecules. So what these psychedelics do to the brain connectivity, and how do we actually get the psychedelic experience? It might appear complicated, but very simple. This is the red one in the center is the thalamus, and the black marks are areas where the thalamus is connected to the sensory system. This is increased when you take psychedelics, and the gray areas are reduced in input, which is to the association areas. So what happens when a person takes psychedelics is his sensory areas connection are increased, and there is an unregulated thalamic input and sensory perception, whereas he is not able to integrate it with the other association areas. So what it does is that the person has decreased integrative processing and increased the sensory processing, and he gets the psychedelic experience at last. So this basically reduces the functional connectivity in the default mode network and association areas, which are known to be increased in depression and other anxious disorders. So now, for reviewing the evidence about these molecules, knowing about these molecules, I will bring out some snippets from this meta-analysis. It has synthesized all the information from 1960 to till now, and all journals published in English. But the process main issue is it's difficult to blind the psychedelics because there is psychedelic experience. The participants were exposed to psychedelics as an individual therapy or an add-on therapy. Even non-RCTs were included in this review to bring in all the evidence. Only the studies which didn't have any baseline control group were experienced. So they consider around 15,000 articles in the beginning, and at last around 59 studies were taken for meta-analysis and another 67 studies for the systematic. So moving on to the first molecule, psilocybin. So as we commonly know, colloquially know it as the magic mushrooms or the shrooms, it's a tryptamine developed from the mushrooms family, which is the psilocybe. After ingestion, it becomes some molecule like serotonin, the 5-hydroxytryptamine. In humans, it produces an altered consciousness characterized by marked perceptual abnormalities, affective distance, and so on. The dosing they have used for this study is around 10, 20, or 50. One very different aspect of this psychedelics is we give only 1 or 2 doses. That's all. It's not taken daily. It's given 1 dose or 2 doses with 3 to 4 weeks apart. And they seem to have long-lasting effects. So these are the summary of the trials which you have for psilocybin. If you see, the disease they have mainly studied for is major depressive disorder, recurrent depressive disorder, and treatment-resistant depression. Almost they have collated around 1,200 participants. The total number of studies are 21, of which 16 have been pooled into the meta-analysis. You would see the effect size that there is a significant effect in improving the negative mood by psilocybin. And it also reduces the abstinent days and the negative mood in alcohol use disorder patients. Now, the clinical trials in this are all having different methodologies. There are trials which are having pre-post comparison, which are having a comparison with placebo, which are having comparison with a low dose of psychedelic, and another which is having comparison with other positive drugs, one few SSRIs like escitalopram also. So these medications have also been studied for terminal illness patients with anxiety and depression, alcohol use disorder, tobacco addiction. So till here, there are some studies, but after this, their studies become very sparse, where it cannot be collated to give strong evidence like attachment anxiety, OCD, cluster headache, migraine, body dysmorphic disorder, and some personality disorders also. Next, moving on to LSD. It's an ergot alkaloid, as already mentioned. It is semi-synthetic. It has high potency for the 5-HT2 receptors. Apart from the 5-HT2A agonism, it has effect on the dopamine neurotransmission. This is the reason why the psychotic potential, or it causing few psychotic, is more in LSD compared to psilocybin. it causes profound acute psychosis-like symptoms, delusional thinking, perceptual distortion, cognitive distortion, paranoia. The main thing when we discuss about psychedelics is the dose matters and the setting matters. They say the set and the setting matters. So now the dose is 100 to 200 in the modern studies, only 2 doses at 3 to 4 weeks apart. Now, when it goes more than 400 and 500, that is when the full-fledged psychedelic experience happens. So it's relatively lesser dose in these medications. LSD is used for life-threatening diseases like diseases with anxiety, for the anxiety and depression accompanying them, and alcoholism. So the studies on LSD was more before the pre-prohibition area than now. Yeah. So the next molecule under discussion is MDMA. MDMA, commonly known as Molly or ecstasy, produced in 1912. These molecules induces monoamine receptors, monoamine release, transporter inhibition. Apart from agonism at the 5-HT2A receptors, it also has an effect on oxytocin. Thereby, it increases the prosocial behavior, or it becomes an empathogen, increasing the socialization. That's why we have heard of all these molecules in the rave parties, that this is being used for socializing by others. So 75 to 125 milligrams in 2 to 3 doses. Now, we have to see the clear contrast in what we are speaking. These molecules we have dealt with as molecules of abuse. Now we are discussing the dosing and for what indications we can use these molecules. So MDMA has been properly studied around 900 participants for PTSD, collating about 15 studies. So many, the phase 3 trials are almost complete and they are submitted for initial approval. There was a setback, and but the best evidence for MDMA is in therapy assisted with in PTSD. So anxiety, depression are all the other indications in which these things can be used. So ayahuasca, this is the molecule which is used in spiritual ceremonies by indigenous people in the Amazon basin. The main molecule here is dimethyltryptamine, and another molecule, harmine, this actually increases the dimethyltryptamine. The dose here is around 0.3 to 1 per kg. Around a 70 kg man would receive around 70 to 100 milligrams in 1 to 2 doses. So here there is good evidence, almost like psilocybin in major depressive disorder and treatment-resistant depression, substance use disorder, and social anxiety disorder and personality. Though ayahuasca has a lot of evidence and effect size, the total number of studies and the number of participants are really less compared to psilocybin. So the one very important thing which we will ask is, how long does this efficacy persist? This is known that even with 1 or 2 doses, this efficacy persists for as long as 6 months to 1 year. So the same efficacy doesn't say that there is a reduction in the efficacy, but there has been evidence which says that around 6 months to 1 year, the efficacy persists. This is mainly because of the molecular and cellular adaptations which I had already spoken, modulated by glutamate release and the dendritic spines, which increase in the neurons and thereby improve the plasticity. So this one very important aspect with psychedelics is many of them are studied along with therapy. When we will have a therapy session, with that 1 or 2 sessions that psychedelics will be given. They say that when the psychedelic is taken, it increases the flexibility in the thought process of a person. It helps the person to open up. It increases the openness in the person. Maybe some people feel that they have more insight into the purpose of life, and the neuroticism increases. These are the psychological variables in which this works on. But the one very important thing is, if the setting is not good, these medications can be harmful. That is, each psychedelic should be given in a particular assisted supportive manner. When the effect of the psychedelic helps in facilitating the psychotherapeutic intervention, it's called psychedelic assisted therapy. There is almost a full-fledged psychedelic guideline by the American Psychiatric Association, Psychedelic Association for Psychedelic Assisted Therapy. When you give a psychedelic session, first you have to prepare the person. Like, you might get these sort of experiences, and after that we will have to process. If there is some abnormal experiences, we will process these things, and we will be able to help you if there is any difficulties. Then medication administration would happen. And at last, integrating these um, psychological experiences which they get and turning into meaningful experiences further is very important so that the person doesn't feel overwhelmed. So at last, the efficacy part of it or the summary of indications is major depressive disorder, psilocybin has better evidence, although ayahuasca has also good evidence. Treatment-resistant depression and recurrent MDD also ayahuasca has good evidence. Life-threatening diseases and related anxiety and depression, psilocybin and LSD also has good evidence. PTSD, MDMA stands out where MDMA-assisted psychotherapy is used. Substance use disorder, alcohol and smoking. It is also known to reduce abstinent days and help in improving their next. So there is one other dosing. I had spoken of two dosing, that is psycholytic low dose or the psychedelic high dose. There's one other thing called as the microdosing. Now, I think this is where people become overboard. They have started giving it to even normal people, healthy individuals. At around 1/20th the dose of the recreational dose, a very low dose was given, and they started feeling improvement in cognition, maybe increase in creativity, health and wellness benefits. So there is very less evidence for this, but this microdosing is also being studied for psychiatric illnesses and illness population, and this is also being attempts at improving the evidence base for this is also being tried. So moving to the next part, the adverse effects for the safety concerns. So we are actually speaking of drugs of abuse here, so that we have to keep in mind and remind ourselves again and again. Like we use alcohol, which causes liver damage. When we see these psychedelics has low physiological toxicity, it doesn't cause much of an organ damage or cognitive deficits, neurophysiological deficits. During the hallucinogen action, the systolic BP, diastolic BP can increase and it can cause headache, weakness, tremors, nausea, drowsiness, blurring of vision, dilated pupils. But that's why a cardiac check is always preferred before the session. And these symptoms are during the session and gradually wanes away. The next thing which we are very much worried of is the dependence aspect. These are drug abuse. What if I give to the person and gradually he becomes dependent on it? Now it's still in the schedule 1 of the drug. When a treatment indication comes, gradually they move it from the schedule 1 and reclassify it into other categories. When they checked for the dependence risk, the one very important factor is what is the effect the person feels. Many drugs like opioids and alcohol, they give an euphoria, but these drugs are known to have a dysphoric tendency. So they say that there is relatively low risk for dependence on these medications. The one problematic or the difficult situation which we can face is the bad trip, where these hallucinogen experiences might be very overwhelming for the patient and they might develop dysphoria, paranoia, panic. This is mainly common in unprepared individuals in uncontrolled situations. So the setting matters and the patients need to be prepared for it. And sometimes the only worried thing is whether it will provoke a prolonged psychosis or it will cause a persistent hallucinogen disorder. Though it is documented in history, they say that it is extremely rare in well-selected and well-prepared participants. What people at risk for psychosis are usually avoided from these medications. They say almost the rate is 0.8 per 1,000 population. Another common problem which people might encounter is like the bad trips, the unconscious psychological material which gets activated, it has to be worked through, or else that itself will cause negative emotions and psychosomatic symptoms. So now what are the problems which a person who wants to do a research in psychedelics might face? The person experiences the psychedelic experience, so how it's very difficult to blind it. There is very less data for acute and chronic exposure. There is a lot of patient bias and expectancies from the patients, and it might differ according to the patient's prior drug experience. We do it in highly selected patients, so the generalizability might be less. And there is patients who are excluded with known risk factors, so it might again not be generalized. And there is absence of rigorous definition. So this is the part which I wanted to highlight about what is being spoken. There is a lot of criticisms which is also there going on about this psychedelic use. Now we know as this is a drug which was prohibited in the past because it was misused a lot and caused a lot of problems to the society. So now they say the science is sabotaged by social media. They say that the hype which is created by this psychedelic is too much, that we are overestimating it. And the clinical trials which has been conducted, this is the Cochrane risk of bias assessment. Around 75% of the studies have low to moderate risk of bias. The clinical trials which has been conducted, and around 25% of the studies have high risk of bias. So we have to take this, the results of these clinical trials, with a pinch of salt. Now there is an article in Psychiatry where they had said that preparing for busting the bubble of the psychedelic hype, psychedelic hype bubble. They say people are overestimating the promise that is not justified by what is and can be known about its therapeutic potential. You are overinflating, and they are asking the scientific community to reduce the hype on these molecules, so that at least for whatever indications it can be used, and the patients who really require it, at least these molecules are available and they don't get prohibited. So there, all said and done, there are intrinsically some advantages. As of evidence now, these don't need to be taken daily, and the therapeutic effects are achieved within hours to days, and it's sustained for several weeks, and it is used for difficult to treat conditions like PTSD, treatment-resistant depression. We all would be struggling with these patients who come again and again with very less improvement in our day-to-day practice. And they have relatively good safety and tolerability profile, and it also helps us to better understand the neurobiology of the illness and neurosurgery. So at last, I want to end with a message that these current research is at crossroads with significant promise, and there are many challenges also. The social and scientific value of these compounds are compelling as they emerge as potential treatments for a broad range of psychiatric conditions. The evidence supports continuous investigations for treating psychiatric disorders, but it is not yet for use by clinical practitioners outside of research setting or first-line treatment. This I want to be very clear. It's not to be used as first-line treatment. One other important thing is these substances are always thought of as epiphenomenon. That a person uses substance use, there should be something else underlying which is making him use the substance. So again, understanding these molecules in that aspect would be useful. So for pervasive, severe, difficult to treat conditions, these molecules are being used. The current data is still insufficient to support the use of psychedelics, and the long-term use of these drugs are yet to be determined, although anecdotal and naturalistic findings would suggest the safety and tolerability of these. I would want to end with this quote: those that fail to learn from history are doomed to repeat it. So I hope that these medications are at least enough regulated and enough studied, so that for the population at need, it is available and can help the community as a whole. Thank you. I'm open for
Thank you, Dr. Kailash, for your extensive elaboration on psychedelics in the treatment of.
So one question from Dr. Bharati is, will the psychedelic assisted therapy help in reducing the evasiveness in acute psychosis when used? So I think that is one indication where we have to be very careful about trying to not venture into psychedelics, because usually these participants are not taken into the trials. Maybe this evasiveness or the lack of openness and rapport, these sort of things would be more helpful when psychedelics are used in the neurotic spectrum, in personality disorders, in childhood trauma, is what I conceptualize, more than acute psychosis. I think it might not be the right setting. The psychosis might not be the right situation. There might be, these are populations at risk. So these might not be the illnesses for which we try these molecules first.